Well, welcome everybody to the third Hexham debate of this series. I've been asked to point out that if you can click like or share on your device on this as you're watching this event, it might pull other people in to join us. So welcome to Dr. Rebecca Fisher. She's the Senior Policy Fellow of the Health Foundation, which is a charity that works to build a healthier nation by properly valuing and investing in healthcare services. Ordinarily, Dr. Fisher works as a GP, but currently she's on sabbatical as the Harkness Fellow in Healthcare Policy at the University of California in San Francisco. So it's silly o'clock in San Francisco, and she's very, very kindly got herself together to appear on your screen. From the perspective of general practice, Dr. Fisher is going to address the issue of the unequal provision of healthcare in the UK, and we're very grateful to her for speaking to us today. Dr. Fisher, welcome.
Caroline, thank you so much, and thank you to all of you for inviting me to be with you. I was going to say this morning, it is my morning. I'm about 7 hours behind you, but I will try my very best to be lucid. I'm going to attempt in the next half hour to convince you of three things. First, that the provision of general practice in England is inequitable. Second, that we won't successfully tackle health inequalities unless we level up general practice. And third, that levelling up is possible. We just lack the political willpower to do it. How are we going to do that? Well, for the next 30 minutes, we'll have a quick whip through health inequalities because they're the backdrop to all of this. I'm going to talk about a sort of 30,000 foot view of general practice. And the reason I'm going to do that is because I think we need to understand a bit of the context of what's going on to understand why the political will has been absent for the last few years. We're going to talk about Julian Tudor Hart, one of my heroes, and the inverse care law. I'm going to show you why the provision of general practice in England is inequitable, and we're going to talk about what we can do about it. So why should you care? Well, most of you are probably familiar with this drawing, the tube map. And many of you will also have seen this. But for those who haven't seen it before, I just want you to take a quick and slightly closer look. This is a schematic map of the London Underground, but instead of the tube station name, it has the number of years of life expectancy a person living near that stop can expect to live. And I'd just like you to focus particularly on the central line, the red one through the middle. If you live at Tottenham Court Road, you can expect to get to a very healthy 96 years. That's pretty extraordinary. But just look with me to the left of your screens, following the line east, and watch the numbers change. By the time you get to Shoreditch High Street, you can expect to live 84 years. Also pretty reasonable. But by the time you've got to Bow Road, that's just 5.3 miles geographically from Tottenham Court Road, you're down to 77. That's a difference in life expectancy of almost 20 years in less than 10 minutes on the central line. Now, why should you care? Well, you could argue that that's reasonable, or you could think like me that that is deeply unfair and unjust, particularly when you realise that health inequalities are things that we can do things about. And I want to add a caveat here, which is important, which is that, of course, not everything about health inequalities lies within the remit of health to change. The social determinants of health play the largest role in shaping health inequalities. The conditions in which we are born, we live, we work, we play, we grow, are responsible for the large majority of the inequality of life expectancy that we're seeing represented on that tube map. But there is a component of life expectancy and health inequalities that is amenable to better healthcare. You'll see different numbers in different places. People sometimes say 10%, sometimes 20%. I think the precise number matters less than the idea here that healthcare can play a really meaningful role in how we tackle health inequalities. And we actually have some pretty specific ideas and evidence for exactly how healthcare can play a role in tackling health inequalities, the specific interventions we need. There's a lot, for example, around the prevention of cardiovascular disease, so on and so forth. I've talked about life expectancy, and that's what you're seeing on this tube map. But I want to also draw your attention to gaps in healthy life expectancy, the difference in of number of years that you can expect to live in good health, because those are even bigger. So healthy life expectancy for men in this country is about 18.4 years different between people living in the most affluent and the most socioeconomically deprived areas. For women, the difference in healthy life expectancy is almost 20 years. Healthy life expectancy in deprived areas is 51.4 on average, compared to 71.4 years in the most affluent. So really, really significant gaps. And important to know that those gaps are widening. Since 2010, life expectancy overall in this country has stalled and is declining. That's pretty unprecedented. It hasn't happened since at least 1900, not since we started doing things like putting in safe water systems. And the reason for much of that decline is that health inequalities are widening. I just want to show you the difference between North Oxford, which is approximately 5 miles away from Blackbird Leys, where I work in South Oxford. This takes probably 20 minutes on my bike with a fair wind, but a gap in life expectancy of 7 years. The gap in life expectancy in Northumberland, closer to you, between the richest and poorest postcode areas is almost 10 years. And before I go on to talk in more detail, I just want a note of clarity on language. And I think probably all of you are aware of this, so my apologies, but I think it's an important difference. I'm going to talk a lot about equity and inequity, as opposed to equality and inequality. And that's very deliberate, because it's the difference between equality, where everybody gets the same, and equity, which recognises that we come from different start points and we allocate resource in proportion to need to achieve equal outcomes. So the language I use is around equity and inequity. But what I want to do for a second is just zoom out to 30,000 feet and talk about what's going on in general practice, because it's the really essential context for the political decisions that frame a lot of these discussions. And I suspect I don't need to tell you, because you read the papers, and this has featured on the front pages heavily through the winter, as have other difficulties in the NHS, but also because you all experience general practice, because you go to your surgeries, you and your families need healthcare. And I really want to hope that you've had an excellent experience of that in the last, always, and continuing over the last few years. But my worry is that you haven't. Because we know that nationally public satisfaction with general practice has sort of fallen off a cliff edge, and particularly around access. But I want to give you some of the context for that. So this graph just shows the trend in appointment numbers in general practice since 2018. So apologies, it looks a bit wobbly, and that's because you're looking at COVID lockdowns and periods of time where appointment numbers really changed. But if you just look at the overall trend, and the scale here is quite big, so it doesn't project quite so neatly on this graph, but the trend is an increasing number of appointments in general practice, and it's a really significant increase. So in January this year, general practice in England, and the data I'm using, I should just caveat in this presentation, is all the English NHS, because of course the NHS is a devolved administration. So all of this, I'm talking specifically about general practice in England. The service did 30 million appointments in January. That's 4 million more than the same time last year. So a 15% increase in appointments done in general practice. And you might say, okay, well, that's fine, as long as there are more GPs. And of course, you'd be right, except that there aren't more GPs, at least depending on who you listen to. And I'm just going to take a second here to clarify stuff around GP numbers, because you will hear some people, government, saying the number of GPs has increased, and you'll hear almost everybody else saying the number of GPs has decreased. So just to explain why that is, as you're probably aware, in 2015, the Conservative Party manifesto promised 5,000 more doctors in general practice, 5,000 more GPs. In 2019, having spectacularly failed to get any more GPs into general practice, they increased the manifesto commitment for this Parliament to 6,000 more GPs, which is a welcome ambition, because we need more GPs, but they weren't anywhere near achieving it. What they have managed to do, and this is great, is to increase the number of doctors who choose general practice as their speciality and go into GP training. So you do 3 years of GP training to become a fully qualified GP, and that's after your first couple of years of doing general rotations. as a doctor in training. So the number of GP trainees has increased. But unfortunately, for reasons that we will come on to in a second, and are largely due to a rather unpleasant spiral of soaring workload, increasing pressures, people are cutting their hours in general practice. And so that pipeline isn't translating into more doctors actually in general practice. So the number of permanent, fully qualified GPs has decreased. And that's why you hear people using different language. So the government will say the number of GPs is increasing. That's because they are including people who are in training to be a GP, but not yet fully qualified. And then folk like me would sort of say, well, yes, but actually those people make a great contribution to general practice, but they need supervision from fully qualified GPs, and we shouldn't really be counting them in their head count. And actually, the number of permanent, fully qualified GPs has decreased, and it's decreased by about 2,078 FTE GPs since that 2015 pledge. So soaring workload, decreasing workforce, really significant workforce problems in general practice is the backdrop to the service at the moment. And just to contextualize that with what's going on in hospitals, I don't want to spend particularly long on this graph. I just want to draw your eye to two lines on it. This shows the change in staff numbers over the last couple of decades. The purple line at the top is hospital consultants. The green dotted line at the bottom is GPs. So you see that we've got this steady increase in the number of hospital consultants. The number of GPs was sort of increasing through the noughties. That was when Labour introduced the new GP contract in 2004, generally pretty popular. Lots of people went into general practice, and then it's sort of fallen off a bit of a cliff in 2013-14 and has been going gradually downwards ever since. So there's this quite a big difference between the trajectories of hospital medicine and general practice. And that graph, I want to be clear, almost all of the graphs I'm going to show you are from work we've done at the Health Foundation. This is not my work. This is John Appleby at the Nuffield Trust. So I will tell you when it's not my work so that we're completely clear. So I'm going to zoom back in to the inverse care law and inequity in general practice, but I want you to hold that big picture view in mind. This chap is one of my heroes. Some of you may recognise him. He is a Welsh GP called Julian Tudor Hart, who died a couple of years ago. And he had been an absolutely pioneering GP in his generation. He was one of the first to systematically collect records of the blood pressure of patients in his practice and be able to show that they were amenable to changes over time, leading to improvements in patients' health outcomes. But he also, vitally for me, and rather a lot of us, coined something called the inverse care law in a paper he wrote for The Lancet in 1971, where he said the availability of good medical care varies inversely with the need for it in the population served. And he went on, and I just wondered whether a couple of you might enjoy this, to say that the inverse care law operates more completely where medical care is most exposed to market forces and less so where such exposure is reduced. The market distribution of medical care, he says, is a primitive and historically outdated social form, and any return to it would further exaggerate the maldistribution of medical resources. So Julian Tudor Hart wrote about the inverse care law in 1971, identifying its existence in the NHS. And the question that I have asked over the last few years is, to what extent does the inverse care law persist in general practice in the English NHS now? And I'm going to talk you through the answer to that in the next few minutes. To do that, I'm going to break the question into a couple of chunks. So we're going to start with, is the need for healthcare equally distributed? And I think you will know that the answer to this is no, but just humour me for a second, because I'm going to show you a couple of graphs so that we understand the extent to which care is unequally distributed. I realise that some of you will love graphs and some of you will hate them. If you hate them, feel free to look away and hopefully you can just listen. I will talk you through and orientate you to them slightly. This first one just shows the percentage of patients who have two or more illnesses by IMD score. IMD, the Index of Multiple Deprivations, is a composite score that allows us to understand how socioeconomically deprived an area is. And number one on the left of your screen, is the most affluent areas. As we move left to right, we go to the most deprived. The different colours are just different age groups. And what we're looking at is the number of people in that area who have 2 or more long-term illnesses. And so you can see very quickly, if you follow that green line from the left to the right of your screen, that as we move from richer area to poorer area, the number of people who have multiple long-term conditions increases. And it increases particularly significantly when we go from the 9th decile of IMD to the 10th. And so people living in the most deprived areas are likely to have 2 or more long-term conditions by the time they're 61. If you live in the most affluent areas, you'll get to 71 on average before you accumulate multiple health conditions. If we think about that in condition-specific terms, and again, I don't want you to look at the detail, but there's one important point I want to make here. These graphs just show you the prevalence of specific chronic illnesses as you move from richer to poorer areas. So blue, for example, is depression, red is asthma, yellow is coronary heart disease, kind of mauvey, red, crimson color is diabetes. You can see that all of those, the prevalence of all of those illnesses increases as you move from richer to poorer areas. And this isn't surprising, right? We know that this is the case. The graph on the left side is in slightly younger people. The graph on the right is people who are over 70. So you can see that this is the case kind of however old you are. The thing that I just wanted to draw your attention to, because I think it is particularly sad and important to note, is that there is one line on this graph that goes the other direction, which is the black dotted line, and that is the line for cancer. So this is the prevalence of cancer by different IMD area, and you can see that cancer is actually more common in richer area, more prevalent in richer areas than it is in poorer areas. And if you think about that for a second, you will of course realize that cancer is more common, the incidence of it, the number of new cases is going to be higher in poorer areas, but the prevalence, the number of people living with it in the community, is lower in poorer areas. And the reason for that is that people who are poorer tend to die sooner of the cancers that they have. And that is partly to do with the type of cancers people get. There are more smoking related cancers in poorer areas, tend to be associated with worse health outcomes. But I just wanted to draw your attention to it, just to remind us of the kind of grim reality of health inequality. This graph is really jaggedy. Again, sorry, COVID, but I just want you to look at the colours. This shows the consultation rates between richer and poorer areas. And remember, the reason that I'm showing you all of this is to paint up a picture of the degree to which demand for general practice is different between richer and poorer areas. So the red line at the top is the number of consultations per person per year in the poorest areas. The blue line at the bottom is the number of consultations per person per year in the richest areas. And they are pretty different. So on average, a person living in the most affluent areas of England will consult their GP 4.5 times. I realise you can't go half a time, but this is an average. And in richer areas, it's about 6, and in poorer areas, sorry, it's about 6 consultations per person per year. Now, you might think that's not a massive gap, but if we just do some kind of back of an envelope maths, let's say you're a practice with 10,000 people on your patient list, and each of them consults 4.5 times a year. So you're a practice in an affluent area. You're going to have on average 45,000 appointments for those 10,000 people in a year. If you're a practice with 10,000 people on your list in a deprived area, and they each consult on average 6 times a year, that's 60,000 appointments from the same group of patients. That's a pretty big increase. It's nearly a 30% increase in the number of appointments that you're going to be doing. And you may reasonably say, well, that's fine. As long as there are more GPs and practices in those areas have more resource to meet that demand, that's not a problem. And you'd be right, except for that's not the case. And that's what I'm going to move on to show you now. So the second part of our question is availability of general practice in England proportionate to need? Now, you probably remember from my list of things I'm trying to convince you of that the answer to this is a fairly resounding no. But let me just show you the data to back myself up. And this all comes from work that we've done, so with Health Foundation colleagues over the last few years. So the first one looks at how general practice is paid. General practice is paid by the number of people that it has on its list, with a bit of weighting for the workload associated with caring for those people. It also has a variety of other smaller income streams, and we can get into the weeds in questions if you want to. But this graph shows you the trend in GP practice payments per patient by neighbourhood deprivation. And all you need to look at is the colour, because we have at the top green, which is the least deprived areas, and at the bottom red, which is the most deprived areas. So what you would expect based on everything I've just told you is that demand for general practice and health needs in the population are highest in our most deprived areas. Therefore, general practice in those areas would get more money to meet those needs. What I'm showing you here is that the opposite is the case. So in this country, general practice in the most affluent areas gets on average 7% more funding than GP surgeries in the most deprived areas. And I will come back to why that is in a minute. How does that translate into workforce? Well, just focus for a second on the top graph here. I'm sorry, it's a bit small, so I've realised you'll probably be squinting at a screen. All you need to look at is the colour, because the colour coding is the same. So this is the number of GPs. And again, you would expect more demand in deprived areas, more GPs in deprived areas. We'd expect to see the red line for deprived areas at the top of the graph and the green line for affluent areas at the bottom. But it's the other way round. What we actually see is that there are more GPs in the most affluent areas and fewer GPs in the most deprived. And after accounting for different levels of need, a GP working in a practice serving the most deprived patients will on average be responsible for the care of almost 10% more patients than a GP serving people in more affluent areas. Interestingly, if you look at the bottom graph, the reverse pattern is seen for nurses. So there are more nurses per head in areas of high deprivation. And the thing that particularly worries me is that there are a disproportionate number of older GPs aged over 65 working in the most deprived areas. And that's obviously worrying because it's more likely that those GPs will leave the workforce in the next few years. So, this is a problem that seems likely to get worse. So, less money, fewer GPs in deprived areas. This graph just shows you how much time people get in consultations. And as we moved from left to right, we're again going less deprived to most deprived. Sorry, this is a slightly different color coding because we published this somewhere else. But the point to understand here is that whether or not you have multiple health conditions, people who live in more deprived areas get less time in their GP consultations than people who live in affluent areas. That's probably not surprising, really, given everything I've already told you, but it is important. And then GP turnover rates are higher in more deprived areas. So this wasn't work we did directly. This is work that the Health Foundation funded, but was done by a team from Manchester University looking at the rate of turnover of GPs. And they found that practices in the most deprived areas have turnover rates that are up to 10% higher than practices in the least deprived areas. And as you can probably imagine, high GP turnover is a problem for a number of reasons. It affects continuity of care, it affects practice morale, it's difficult for practices to recruit, it's very expensive to do that work. It, on a number of levels, affects quality of care. So to summarise, compared to more affluent areas, general practice in areas of high deprivation has greater population health need, has higher consultation rates, it receives less funding, it has fewer GPs, and it has shorter GP consultations. And just to sort of complete the picture, general practices in deprived areas perform worse on all three major quality indicators. And I'd caveat this slightly by saying that these quality indicators are slightly blunt markers. There are lots of facets of the quality of a practice that aren't really captured in these big national surveys and inspection regimes. But nonetheless, practices in deprived areas do worse on QOF. That's the kind of pay for performance scheme for GPs. They do worse on CQC inspections on average, and they perform more poorly in the GP patient survey. So, hopefully by this point, I will have convinced you that the provision of general practices in England is inequitable. What I'd like to do now, and sorry, this is looking slightly strange as a slide on my screen, but is talk to you about why I don't think that we will be able to tackle health inequalities effectively unless we level it up. And this is the concept of proportionate universalism, which those of you who have read or listened to Michael Marmot speak before will be very familiar with. So this is the concept that the resourcing and delivery of universal services must be at a scale and intensity proportionate to the degree of need. Now, right at the start of this talk, we talked about health inequalities, and we've now talked about the inequity in the supply of general practice. The challenge that we have is that, as I said, we know a lot about how we can tackle health inequalities through healthcare. We have a good sense of what interventions we need to put into place to do so. But if you roll out an intervention across the country, in the context of inequity in the supply of general practice, what is going to happen is that intervention is more available in the most affluent areas than it is in the most deprived areas, simply because there is more resource to deliver it, more GPs, more appointments to go round, so on and so forth. Now, of course, there are people who experience socioeconomic deprivation who live in affluent areas. So I don't think that it is a bad thing that we roll these things out across the country. But until we level up the provision of general practice, every time we do that, we paradoxically risk widening health inequalities. Because let's say what we're trying to do is control everyone's blood pressure really well. That requires some degree of engagement with your general practice. But if it is structurally harder to get a GP appointment in an area of high deprivation, and you get less time in each appointment, then we end up in a situation where actually the interventions that we need the most are least available in the areas that we need them. So I would strongly suggest to you that until we tackle inequity in the supply of NHS services, it is very difficult to meaningfully tackle health inequality. And I'm just going to spend the last few minutes talking about why I think that levelling up is possible. And this is the sorry story of the Cahill formula. So remember I said a few minutes ago that the way that we pay for general practice is that practices get paid by the number of patients they have on the list, but there's an adjustment made to that payment for an approximation of the workload that is involved in caring for those people. We acknowledge, for example, that it probably takes more work to look after an older person than it does a person in their 20s. And so the formula has a weighting on it, and the formula is called the Cahill formula. And it adjusts for a bunch of things. It includes age, but also things like rurality, the cost of employing staff. What it doesn't adjust very well for is the need associated with socioeconomic deprivation in a population. This formula was introduced in 2004. Before that, there was a system called deprivation payments, which were literally really top-up payments for practices in deprived areas. But the theory was that this formula would replace that and do the same job. The problem is that it didn't, and that was recognised pretty quickly. And in 2007, a formula review group was convened by the government of the time, tasked with looking at how well the formula was performing. And they reported and said very specifically, it doesn't do well enough at adjusting for need associated with deprivation. It's skewing payments towards affluent areas, and you should put in an adjustment for IMD score so that you can redistribute funding a bit more effectively to practices in deprived areas. That recommendation was never accepted by government, but the reason for that was largely that it was put to a vote of GPs by the BMA, and GPs voted against it. The reason, I would suggest, of course, we don't know what the individual reasons for all of those individual GPs voting for it were, but my hunch is that the reason that the profession went against it is that to level up at that time, there was no extra money on the table, so it would have required taking money from some practices and giving money to others, which is always going to be an unpopular move. And since then, it's never gone to a vote of the profession again, but there have been multiple policy papers calling for reform of the Cahill formula, including national plans for the NHS, things like the GP Forward View. But it hasn't happened. This is me chatting to the Health Select Committee this time last year, trying to make this same point looking slightly strange, I grant you, whilst doing it. And it did go into the Health Select Committee's report. Here they are at the bottom of this paragraph, saying the government and NHS England must develop a better mechanism to award funding to more deprived areas to replace the Carhill formula, which is insufficiently rated for deprivation at present. The funding change should be used to support further work to ensure equal access to general practice across the country. Fantastic, but has it happened? No. And it's back to that question of how we deal with the actual financial levelling up. And what I would suggest to you is that the way around that is to put a bit of money in, so that nobody loses out, so that practices in more affluent areas are held, at or a little bit above their current level of income. Because back to that 30,000 foot of general view of general practice, the reason I showed you that is to say nobody is having this easy. General practice does 90% of patient contacts in the NHS for around 9% of the NHS budget. Funding to general practice as a whole has not kept pace with funding to the acute part of the health system, hospitals, over the last 20 years. So the service as a whole is really struggling. My personal view is that I don't think the answer is to take from some and give to others. It's to put more money in and use that money to level up, so that you can keep practices at an affluent area at one level and you bring practices in deprived areas up to a higher level, so that you are adequately resourcing in proportion to need. The reason I say that involves political will is because it involves money. It probably doesn't involve a huge amount of money at all, and certainly not in the context of the wider NHS budget, but it would involve this being a priority for government. And I just want to, in conclusion, say that I know that this isn't all about money. So a lot of the graphs that I showed you were from this briefing that we did in 2020, looking at how equitable or inequitable the provision of general practice in England was. We then went back and published this time last year the piece on the right of your screen, Tackling the Inverse Care Law. And what we had done is we looked back at the range of policies government had tried over the last 30 years to level up general practice in England. And we talk a lot about funding, but we also talk about other things that were tried, for example, in how you commission for services, and really importantly in workforce. And there is a tie between funding and workforce, because the income that practices get directly determines who they can afford to employ and how much they can afford to pay them. But it's also clear that government can act to make the distribution of GPs more equitable. And just one example of that is something called equitable access to primary medical care, which was a policy that New Labour put in 2007. It was funded until 2011. And they literally paid to build new health centres in socioeconomically deprived areas. The pledge was for over 100 of them. And that pledge was fulfilled, and it was a kind of build it and they will come philosophy. And it appeared to work. By the end of that decade, by 2010, we had more GPs working in more deprived areas. Fast forward about 4 years, that policy had ended. A bunch of other policies that were aimed at tackling health inequalities had ended, and the distribution of GPs had started to change, and the gap has been widening ever since. So we now have, as I said to you earlier, more GPs working in more affluent areas, fewer GPs in more deprived areas. But the point I want to make is that good policy can change this. So this is not an inevitability. If government were willing to prioritise this, things can change, because we know that change has worked in the past. So hopefully I have tried to convince you of these three things: that the provision of general practice is inequitable, that we won't successfully tackle health inequalities until we level it up, and that levelling up is possible. It just requires political will that isn't currently there. So all that remains is for me to say thank you so much for listening, and I'm very happy to take any questions.
Well, goodness me, that was a parade of absolutely killer statistics. Well, I shouldn't say killer in the health sense, certainly jaw-dropping statistics. So I'm going to invite you now to put your questions for Bex Fisher into the chat box. There is one there already from Annie Bishop, who says, it's very difficult to attract GPs to remote rural populations, especially with an ageing and often housebound patient demographic. Would the suggestions that you've made for reform perhaps address that?
It's a really great question, and it is a very difficult issue. There are some areas, whether it's rural, whether it's deprived coastal areas, that we know that it is just harder to get people to work in. But we also know, primarily from past experience, that there are things that you can do to attract people into those areas. The government actually has something at the moment, which is a Golden Hello scheme for GP trainees, which pays them, it's about £20,000 over 3 or 4 years to go and work in an area that has been historically underdoctored. And that scheme is consistently filled up, which I think is a good sign. So it seems that financial incentives can play a role in encouraging people into otherwise underdoctored areas. We also think that those incentives seem to be more effective earlier in people's careers. So it's harder to get people who are, perhaps in their mid-40s, perhaps already have kind of roots in an area to move, but we know that incentives do work quite well with earlier career GPs. Something that is an issue is that I mentioned earlier that we have GP training. GP training is, as you would imagine and probably want, quite a regulated thing. You can't just train in any old practice. It has to be what we call a training practice. It has to be fully accredited with doctors who have done extra qualifications to supervise trainees. Those practices are more likely to be in more affluent areas, and people are more likely to stay in the practices in which they trained. So I think part of this is also getting practices in areas that are underdoctored, so remote rural populations, coastal populations, deprived socioeconomic urban populations. We need more GP trainees in those areas because we know that people then tend to stay. And I think that's probably a lot of factors, including that obviously medicine isn't quite the same wherever you practice it. And there is something about getting comfortable with looking after the needs of specific patient populations. So it's not a perfect answer to your question, Annie, and thank you for it. But I think we know that financial incentives can play a role. We also know that how we train people is really important. And we know that where we train people is really important. And those are 3 things we can all do more on.
Okay, here's another question from Annie then. Was anything done with the Black Report? Perhaps you could just tell us what the Black Report was.
I don't know is the answer. I think the Black Report goes back, and Annie probably knows more about it than me, but to the early 1980s. It was outside the scope of policy changes that we looked at for the report that I just spoke about, which was the 1990s onwards. So I don't know how much happened. I guess what I would say, and this probably doesn't answer your question completely, Annie, is that what I have found is it's very difficult to know when government doesn't do things. So for that report that we did looking back at policies over the last 30 years, when you look at these reports, they will have a whole slew of recommendations and commitments. You then try and follow up each of those and see what happened to them. It's usually reasonably easy to see when government has done something, and it is very, very difficult to follow the paper trail to when government hasn't done something, and you try and look at the money and where it's gone and what has happened. And you just kind of reach a dead end. So I don't know how much directly came out of the Black Report. My experience has been that finding exactly how government has done on its commitments can be quite hard, particularly when it hasn't met them. And that's not just this government, or it's, I think a fairly common trait.
Okay, well, if I jump in with a question now, the front of the Guardian today has a big headline that during the height of the pandemic, and presumably this is still going on, doctors were being offered a £5,000 incentive to encourage their colleagues to enroll to work for an American private healthcare company. This seems to me to be the absolutely opposite of what's needed if we're really serious about levelling up. Private healthcare moving in is the last thing we need, and we shouldn't be allowing doctors to move. Well, how could you stop it? Anyway, that's that. Could you comment on this story in the paper today?
Yes, of course, and being clear that these are personal views, not those of GP practices or the Health Foundation. But I think the first thing I would say is that partly this is about legislation. There is that is, of course, completely legal under our current legislative framework, that these companies exist, that private healthcare is a part of our health ecosystem. In the NHS, it probably accounts for between 8 and 10% of healthcare use in this country. So partly this is thinking, what kind of legislation make any changes to reduce this if reducing the footprint of private healthcare is thought to be desirable. But I think the second thing to say, particularly in the context of all of the disputes that have been happening recently, is thinking, well, why is it that people would want to go and work in a private healthcare system? And what can we do to make the NHS the employer that it needs to be to keep people? And how do we make sure that public sector pay keeps pace with a reasonable expectation of, I don't think it necessarily needs to keep pace personally with private sector pay, but it needs to not feel, people need to feel valued in their job. And one way that we make people feel valued is in how we pay them. I don't think those practices are new. I'm pretty familiar with those type of phishing emails coming into my inbox. They have done ever since the start of my medical career. My concern that is, as conditions become worse and worse in the NHS, that may seem more attractive to people. And I think particularly in the context of general practice, I mean, I find the whole thing terrifying, but particularly in the context of general practice, I spoke to you about the number of GPs. Like, it really is pretty desperate. We did projections from the Health Foundation last year. So we looked and we said, well, what can we expect in the next 10 years? And we had a sort of, they're not an optimistic and a pessimistic scenario. And in our pessimistic scenario, which I didn't think was actually that pessimistic in the modelling, we had a shortage of 1 in 2 GPs by 2030. That would mean half of GP posts vacant. That is a kind of worst case scenario, but it is absolutely terrifying. And GPs are cutting back their hours, and some of them are going to work for private providers who will offer, effectively telemedicine to folk. And we know that the folk who consume that type of medicine tend to be younger, more affluent, have fewer health conditions. So yes, I find it completely terrifying. My personal experience is that NHS work is deeply fulfilling. I think we also have to think, how do we make the NHS make sure that it is an employer that people really want to work for? And that's partly about how we make people feel valued in their work.
So there's a question coming in. Just hang on a sec. So this is from Peter Woods. How can GPs reduce the number of no-show appointments when people make appointments and then don't turn up?
It's a very difficult question, Peter. I don't know a single evidence-based answer. I know that people have tried lots of things, and I think that it becomes difficult because they all have kind of downsides. So there is some evidence that shows that if you text people and remind them about their appointment, they're more likely to come to it. And I suspect most of you get that. If we were in a room together, which would be lovely, but I'm in San Francisco, I'd ask you to stick your hands up if you get a text reminder from your GP, and I suspect a lot of you do. There's also a bit of evidence that shows that if you attach the cost of the appointment to that text reminder, people are even more likely to pitch up. And some of you might have seen that happening if you have a hospital appointment, for example. They will say the cost of this endoscopy is £560. And of course, you're not liable for the cost, but we know that if we remind people of the cost, they go. And the cost of a GP appointment isn't £560, it's about a fifth of that, but it's not nothing. So there is some evidence that doing that helps. So reminders, but reminders with cost. That's the only thing that I've ever really seen hard evidence for. Beyond that, people have tried in different ways to reduce this, and practices will have different systems. So some practices will say, well, the best way that we reduce no-show, or what we call DNA, do not attend appointments, is by making appointments bookable only on the day. Because if someone books it today, then I know that they're going to show up. But the problem with that is that you actually need people to be able to book appointments in advance for a bunch of reasons, including that it's deeply irritating if your GP says, and I'd like to see you again in 3 weeks, and then you're left having to make a note in your phone to say, ring GP surgery in 3 weeks. So in terms of how we manage appointments, I don't think that I have ever seen a perfect way to reduce DNAs. And I think it's sort of part of our social contract, isn't it? And I think we all accept that sometimes people don't show up because of a bunch of reasons that mean, that weren't intentional. But one last thing that I would say on this point is I think that there are things that we can do in more deprived areas to help reduce barriers to attendance. So in some areas, surgeries or in collaboration with other organisations can go out and get people. Why is it that people aren't coming? So we would never say a child didn't attend because the child wasn't bought. Children can't attend or not. Children can be bought or not bought to an appointment. And the same actually goes for an awful lot of adults. It's not necessarily they don't want to attend, it's that something has stopped them from being able to attend. So I think with lots of these things, trying to understand the root causes of not being able to attend might lead to somebody saying, well, okay, might just be a voluntary system for picking people up from their homes and making sure that they can get in, because if the taxi doesn't pick them up, that's not their fault, but their health suffers. So there's no one neat solution, but I think we also need to go a bit deeper, particularly in deprived areas, and say, how can we help people to attend? But that, of course, requires resource to be able to do.
Thank you. Hugh Grant asks, is there anything to be said for making a small charge for appointments like they do in Ireland and France, with protection for low-income people who can claim the charge back?
Yeah, again, a great question. My fairly straightforward and personal answer to this would be no, for a couple of reasons. Number one, if you look at the number of people who we would need to exclude from any such system, it would probably be about 90% of people who would end up not paying. And that's based pretty much on the number of people who pay for their prescriptions or not. But once we exclude people who are on some form of benefit, over an age cutoff, have long-term health conditions, all the people who would legitimately be excluded from payment, it's actually the vast, vast majority of people. So you would be left trying to collect payment from a very small number. We don't actually know that that small number left are the people who aren't turning up, because presumably the point of this is to try and somehow either limit demand or to make sure people show up to appointments. But we'd end up charging very few people. We have absolutely no infrastructure to be able to charge people for the NHS. And we don't have any evidence that this would improve outcomes. And I suspect that it would likely worsen health outcomes and health inequalities. And because you inevitably create a cliff edge, my personal view is when you stack up those against the possible but unknown benefits, you end up with a fairly resounding no for charging for general practice. But I also accept that it is a question that is going to rear its head whilst we have these ongoing access problems. I would suggest that what we should do instead is think about what the root cause of the access problems are, try to resource general practice properly, and then end up in a situation where we're no longer having to think about how we try and stop people from coming to see us because we don't have the resource to deal with it. But that is, again, back to what is politically possible.
Thank you. Another thoughtful answer. Chris Drinkwater asks, what's the role of new medical schools, such as the one in Sunderland, in reducing inequity in distribution of GPs?
Probably a lot, I think, very encouraging. So there are 5 new medical schools across the country, and they were quite thoughtfully, in my view, placed in areas where there has been previous underdoctoring, particularly in general practice. So as a baseline premise, I would say optimistic, but there is a caveat, which is that optimism would be rapidly tempered by a bunch of things, included. So I showed you that graph that shows hospital consultant numbers sort of soaring in the last 20 years while GP numbers have plateaued and then fallen. Ultimately, where people end up is a result of workforce planning, and that we have a history of pretty terrible workforce planning in the NHS. We're all desperately waiting for the long-term workforce plan, which is due out any moment. But it will be a first. We don't really have a history of great workforce planning in the NHS. So you have to think about the whole pipeline. So these people also need to want to go into general practice. So it's great that we're putting medical schools in places that have been historically under-doctored, but there's a long way to go before those people become GPs. And part of this is about how we plan, so where we make training places available in what specialities, but part of it's about how attractive a career is to somebody. And I guess my question is, how do we make sure that general practice is a career that people want to go into? How do we get these, 20-year-olds in medical school to look at general practice and think, that's what I want? And it's very difficult when the Daily Mail is slamming GPs. GPs are quitting because the workload is just horrific, and there's this negative narrative around it. And the final thing that I would say, and I don't know the medical school curricula of these in detail, but is that general practice has historically been quite underrepresented in the medical school curricula. You spend a lot of your time as a medical student in hospital-based specialities, and so you just have much more exposure to them. And I think it's really important that we get medical students out into community medicine in all its forms very early in their medical training, so that they get to experience it and get to think from an early point about whether or not that could be for them.
I can't see any more questions on the screen at the moment. Perhaps I can come in with another one. What's happened to home visits? Once upon a time, your GP would see you in your house if you couldn't get yourself to the surgery. That seems to have vanished into the past.
Interesting, Caroline. I mean, they're still there. They're part of the GP contract. I think the way that they are, it's interesting. I mean, I suspect, again, if we were in a room, we could have a conversation about this, because I'm interested to know what people's experiences of accessing surgeries are at the moment. And I suspect they're pretty different. And that's partly because surgeries are very different and do things in different ways. At the surgery that I've worked in for years back home in Oxford, we do still do home visits, but the way that we do them has changed slightly. So it used to be that the GP would go out in this mythical thing called lunch. Now we have a home visiting team. So across the city, we have a group of doctors and home visiting paramedics who we refer to. They will go and see the patient. They will then report back to us. And there are pros and cons of that. And sometimes I will just go and see a patient when there are specific exclusions to who can be seen by the home visiting team. So, for example, in Oxford, people for end of life care would never be appropriate for a home visiting team service. That would always be the GP going out. But also sometimes I just think, well, I want to go and see them for whatever reason it is, and we'll go. But I think that it's practice specific how home visits are handled. And I also think that it's back to that backdrop of appointment, like of demand just being through the roof, and practices really struggling to be able to meet the needs of all patients. And I'm sorry to hear that it's harder to get a home visit for you at the moment in Hexham, but not surprised, because I think that's the context we're working in.
Okay, so this is from Howard Maskill. How large is the private GP sector currently?
Great question, difficult to answer, because all of the data that I have ever seen on it is generated by the private providers themselves, which means that I would so if you look at data from private providers, they will say it's growing. And they will say the percentage it's growing by is big, but actually in absolute numbers, it's small. It's a relatively small proportion of the UK population. I think around 1 million a year who consult a private GP. And private GP services, I think in the last few years have kind of evolved. Most people aren't going to a private in-person doctor. This is a kind of Livy or Babylon GP at hand, tap my phone and speak to someone 10 minutes later, private GP service, which is private general practice nonetheless. And so the numbers certainly are increasing, but I think they are increasing, number one, from a very small base, and number two, not particularly quickly. But the major caveat to that, Howard, is that the data is released by the private companies who want to tell you how much they are growing and how well they are doing. And because it's not within the NHS system, we don't have national appointment data. So we don't really know. What I would also just add is that there is quite aggressive, is that those companies are going for GPs. That, you know, as a GP, I get a lot of invitations to go and work for these companies who offer very good income for a small number of appointments. And it's sort of back to Caroline's question. It is difficult, and I wouldn't judge any of my colleagues who are working in predominantly very difficult conditions, and these companies are offering you more money for less work, and often doing it in your home environment. So difficult.
Okay, this is Annie Bishop again. What do you think about social prescribing in surgeries?
Annie, I'd love to know. I'd love to know what you think. So I've been writing a paper recently looking at how we screen for social needs in surgeries. And actually, there's a research group out here in San Francisco that's probably the world's leading group looking at social prescribing. They're called Siren. I think there are some really important questions in here. So by social prescribing, what I'm taking to mean is the prescribing of non-medical interventions for people's broader health needs. So prescribing exercise, linking people up with charities if they are lonely, in debt, in food poverty, etc., etc. I think that is I think that is a good thing, right? Because we can't just put a boundary around someone and say, we're caring for your blood pressure, but not the root causes of this. I'm going to prescribe you insulin for your diabetes, but somehow not care that you don't have a fridge and insulin needs to be kept cool. Like these things, I don't think we can neatly hive off people's health conditions from the wider conditions that they live in. So it makes intuitive sense to me that we are thinking about people holistically, as I think, actually, to be honest, general practice always has, but this is a formalized way of doing it. There are some caveats. Number one is, how do we screen for this? So at the moment, social prescribing it's been rolled out across the country. Most surgeries will have access to a social prescribing link worker, but we're not systematically screening people for social needs. So there is a real question about that, because my concern is, are we actually getting help to the people who need it most? Or are we just getting help to the people that we remember to ask? And are the people that we remember to ask, that is going to be structurally determined by biases we all carry around who might need what. So should we screen for social needs is a real active question. And how should we do that? And is it acceptable to patients to do that? And how do we keep that information in medical notes? All very live questions. And I think there's a bit of a cart before the horse, because ideally we would have sort of answered those first. And then I think my final point on social prescribing is that we need to think about what assets there are within communities to prescribe to. And as all of you will know, there's been quite a lot of asset stripping in communities over the last 13 years in particular. And I think it's a bit unfair that we sort of pass people on to third sector, voluntary and community sector organisations without thinking about how we resource them properly. And there has been more asset stripping in the most deprived communities. So although I intuitively think social prescribing is a really good thing, I think we also have to think about how we support the infrastructure in communities that supports those communities, and how we do that most in our most deprived areas.
Yes, it's all of these things have so many layers, don't they? So this is the last question that we'll have time for, I'm afraid. Chris Drinkwater asks, what would you be saying to the Labour Shadow Health and Social Care Secretary?
What a great question to end on. Personally, I would be talking to him about general practice. And so I would be saying, as I have said to you today, I would be setting out that same evidence, and I would be making those same 3 points to make the case for why we have to level up general practice. And my very concrete ask would be that we put some money in, which will be a small amount of money. It would be probably in the low hundreds of millions, which is not a lot in government spending terms, to make sure that we bring practices in the most deprived areas up above practices in the most affluent areas, so that resource aligns with need, and we will better be able to tackle health inequalities. So that would be my ask around general practice. But I think the other thing that I would say to him is that the evidence from the previous New Labour government, which had a real focus on tackling health inequalities, is that you can make a meaningful difference with government policy, and to not forget that, and to go back to that, and to think about how we, I've talked to you specifically today about general practice and the need to level up general practice, but everything happens within the wider context of our health and social care system. And if you have governments that have a focus on improving the NHS, if you have governments that have a focus on health inequalities, you can make a real change. And I think we've all lived through a series of governments where that hasn't been the case. We're now feeling the effects of that. So I would encourage Wes Streeting to remember how much government can do when it has good policies.
Well, thank you very much. I'm sorry that we've run out of time. We've had such a breadth of vision given us today. I'm sure there's plenty of food for thought for everybody, and I think I'm going to have to go back and listen to it all over again so I can keep some of it in my mind. So to follow up Dr. Fisher's talk, next Saturday, the 25th of March at 10 o'clock at the St Mary's Centre, there will be an in-person event linked to this theme of the health service and the inequalities of it. A panel of 3 speakers with local and regional knowledge of health provision will look at how the issues raised in today's talk might impact us locally and what solutions might be found. The panelists will speak briefly, and the remaining time will be for discussion for everybody. Everybody's welcome. Admission is free, but there'll be a retiring collection. And this event is a joint initiative between the Hexham Debates and Tynedale Transformed. The 4th online Hexham debate, the next one will be on Saturday, the 22nd of April at 11 o'clock, when Professor Barry Gills will speak on climate action after COP27. We hope to see you then, but with renewed thanks to Dr. Fisher for a fantastic presentation. That's all for today. Thank you.
Thank you.